All right, Chiefs. This is Jacques. I'm going to give you a talk on neuropathies of the upper extremity. Lower extremity neuropathies are not included on this, like tarsal tunnel syndrome. This is going to be the quick and the dirty. I'm going to avoid any extraneous fluff. This is the topics that we'll be covering. In order of importance is carpal tunnel first, cubital tunnel second. I put nerve injuries at the very last, but it's probably actually after the cubital tunnel. And then the other stuff is going to be covered very, very lightly. So carpal tunnel, we're beginning with. Carpal tunnel is going to be most likely the overwhelming majority of the questions if you get questions about neuropathies. The anatomy is crucial. Remember that it's 9 tendons. You have 4 FDS, 4 FTP, and then the FPL. The median nerve is superficial. So if someone has a wrist laceration, the median nerve is very likely to be cut. If they cut the palmaris longus, you have to assume that the median nerve is cut. So if there's some question about a self-inflicted wrist laceration or anything like that, the median nerve is cut unless it's been proven otherwise. At 43 is greater than 25. Remember that for a spaghetti wrist, so if someone cuts multiple tendons, the middle finger and the ring finger FDS tendons are sitting above the index finger and the small finger FDS tendons. So the diagram that you see there is actually incorrect. You have the 4 FDP tendons that are deep, and then the 2 and 2 FDS tendons, so they're stacked 2 and 2 on top of each other. So that's how you know if you have a spaghetti wrist, what orientation to sew them back in. So just remember, 43 is greater than 25. FTPs are obviously the deepest. There's 4 of them. Know the bony borders. It's the carpal bones and the hook of the hamate. Is the transverse carpal ligament attaches to that. Is a very, very strong attachment. Other than that, it's the radial carpal bones and it's the ulnar carpal bones. It's not complex, the bony borders. The other thing to remember is the recurrent motor branch. The recurrent motor branch is a structure that's at risk. This is one of the biggest structures at risk. It can be coming through the ligament. It could be traveling underneath the ligament. It can be on top of the ligament, or it could be in its normal position where it takes off after the ligament. So the recurrent motor is the biggest thing to get injured that you need to be mindful of. It's radial, so stay ulnar. The ulnar neurovascular bundle can be injured as well because it's actually very close to the carpal tunnel contents. It's sitting on top of the transverse carpal ligament and ulnar. And then the sensory branch of the median nerve, if you pass proximally and you aim radially, you can cut it. So those are the 3 structures that are at the greatest risk, with the recurrent motor branch being the most likely or the most serious. Ulnar vascular bundle would be pretty serious too. So risk factors are you have a slight propensity of females compared to males, obesity. Pregnancy is a big one. Pregnancy is for carpal tunnel, for de Quervain's, not so much for trigger fingers, but de Quervain's and carpal tunnel are the 2 most common that you see. Hypothyroidism, inflammatory arthropathies, mucopolysaccharidosis, mucolipidosis, and then also for heavy manual labors. You see that with heavy manual labors. Office workers, people that type all the time, no, that is not a risk factor for carpal tunnel, but it's high impact. Construction workers, guys that use jackhammers, things like that. The pathophysiology is repetitive pressure or motion at the carpal tunnel, where motion of the nerve is actually being tethered, so the nerve doesn't glide well. So nerve gliding is healthy, is normal. You want your nerves to glide. So anything that pushes on the nerve or prevents the nerve from gliding is bad. That's why nerve glide exercises can be helpful with physical therapy with carpal tunnel. Space-occupying lesions, gout, mucopolysaccharidosis, those things have to be ruled out. So, for instance, if you have a kid that has carpal tunnel syndrome, you have to think like, could this be an MPS? Because that is atypical. But most of the time, these are idiopathic. Presentation is crucial. This is a clinical diagnosis, so patients have nighttime symptoms, big one. Symptoms are aggravated with specific activities, holding a book, reading a book in bed, talking on a phone, holding a steering wheel, holding onto a subway pole, numbness and tingling in the radial 3.5 digits because it's the ulnar, the radial border of the ring finger is innervated by the median nerve, so it's 3.5 digits. But thumb, index, and middle is the biggest. And then many times patients do have this aching pain in the wrist. So they may not have numbness and tingling fingers, but they just complain of aching pain. But that aching pain is brought about by these reproducible activities. They can also have weakness in the hand. Difficulty with fine motor movements, that's more ulnar nerve than it is median nerve, but weakness in the hand can be seen. So on exam, the most helpful test is the Durkins. So that's pressure over the carpal tunnel. The modified Durkins is a combination of the Phalens and the Durkins, where it's pressure over the carpal tunnel with wrist flexion. That is the most specific test, but Durkins or modified Durkins is, if they ask, that's the test that you want to be positive. Thenars at the wrist and Phalens, where you bend the wrist and you leave it bent for 30 seconds to a minute, or Thenars where you tap over a nerve. Those are helpful. Thenars is non-specific to a median nerve, but Thenars test is useful for any nerve injury, anywhere in the body. So just remember that. Decreased sensation is a common finding, especially when symptoms are moderate to severe. But remember, it's actually monofilament, so light touch that gets affected first, not the 2-point discrimination. So with compressive neuropathies, they may ask this, it's monofilament. So how many grams? That's how monofilament testing is measured. It's the pressure is by grams on the finger. Weakness of the Thenars and atrophy is a late finding. That's more severe. And what you test there is the APB, abductor pollicis brevis, with palmar flexion of the thumb. Remember the thumb, sorry, not palmar flexion, I meant to say palmar abduction. Disregard the flexion, I apologize. So it's abduct, the thumb can abduct in two planes. It can abduct radially, like in a thumbs up, or it can palmarly abduct. If your hand is flat on a table and your thumb points up to the ceiling, that's the APB, that palmar abduction, not flexion. Disregard that. So on exam, this is something that you may be asked. Is ultrasound has become arguably a better modality than nerve conduction studies and EMG. So there's a lot of evidence now that supports it. So that very likely could be something that you're tested on. And it is a cross-sectional area greater than 10 millimeters squared, so greater than a centimeter squared. That is as sensitive, if maybe even more, than nerve conduction studies or EMG for carpal tunnel syndrome. That hasn't been validated for the other compressive neuropathies yet that I know of, so I doubt that you'll be asked that. With nerve conduction studies, it's prolonged latencies, slow conduction velocities. EMG, you'll see fibrillations of the specific muscles that are innervated by that nerve, and decreased motor unit recruitment. I doubt that they'll ask you specific values, but if you see that the conduction velocity is slowed, if there's prolonged latencies, or if there are fibrillations or decreased motor units, those are all indicative of nerve injury of the nerve that they're examining. So patients present. Splinting is very, very important with early carpal tunnel. Steroid injections are somewhat debated, but that is definitely a legitimate early modality to theoretically decrease the swelling and the inflammation in the carpal tunnel. And nerve glide exercises. Remember I said that compression, but also tethering of a nerve and preventing it from gliding is believed to be part of the pathophysiology. So nerve glide exercises, basically where you just stretch the wrist and induce the nerve to be gliding back and forth. So when symptoms are moderate or severe, and moderate is defined as constant, objective decreased sensation, objective weakness, constantly subjective change in sensation. Those are moderate, and then severe is atrophy. When things are moderate to severe and you fail non-operative, then operative. If things get really severe and people have atrophy of the thenar musculature and they're not able to abduct, palmarly abduct or oppose the thumb, then you can do a tendon transfer. Tendon transfers are very helpful. I doubt that they'll ask you the specific tendon transfers, but just remember there are a bunch. CAMETS is you take the palmaris longus, FDS of the ring finger, EIP, ECRB. It's debated. People have various reasons, but just remember that you have the tendon transfers that are an option. As far as surgeries go, you get endoscopic versus open. I'm sure very few of you have seen endoscopic. We just don't do them at the institution here, but there's nothing wrong with them. There's back and forth evidence about which one is best, but for you to remember on the test, is that most likely, if they do ask something about it, it's quicker recovery with endoscopics. There's possibly a higher occurrence, possibly a higher rate of iatrogenic injury in endoscopics, but I doubt that they'll ask you those specifics. It's a quicker recovery, but at the end, 6 months, a year out, everyone's equal. If people have continued symptoms after surgery with carpal tunnel, you have to think, okay, one, either incomplete release or it's severe carpal tunnel syndrome, so it's irreversible injury to the nerve, so they won't recover, or it's an incorrect diagnosis. This is why EMG nerve connection studies are helpful, because if it is severe carpal tunnel syndrome, you have more of an objective data point that you can get after the fact to see if it's worsened. If it's the same, then we know, okay, your nerve was really badly injured. If it's past this point of injury, it's unlikely to recover. And ultrasound can be helpful to diagnose an incomplete release. Incorrect diagnosis is a concern as well with the cervical radiculopathy or peripheral neuropathy that can present in the same fashion as a carpal tunnel syndrome. If someone has return of symptoms, so it's very important, did they have resolution of the symptoms? Was there improvement in their symptoms? If there was improvement in their symptoms, how much of improvement in their symptoms? And if their symptoms are worsening, is it the transverse carpal ligament that's rescarring or reforming? So if they've had near complete release of the improvement of their symptoms, then it's the reformation of the scar. But if they had just moderate improvement, then you have to think of incomplete release. Cubital tunnel is the next most commonly tested neuropathy, compressive neuropathy. And here, just know the structures that could possibly be constricting the nerve. This is going from very proximal to distal. This is a relevant thing to know, and that could come up on the test. First of all, it's the intermuscular septum. Remember that the ulnar nerve higher up in the arm is traveling with the brachial artery, traveling with the median nerve. It's an anterior structure. It's anterior to the intermuscular septum. Only at the midpoint of the arm does it dive deep to the intermuscular septum, posterior to the intermuscular septum, and become a posterior structure. So the intermuscular septum, one, can be a point of constriction. Arcade of Struthers is basically that fascial area where it's diving through the intermuscular septum. So that's another point. I listed intermuscular septum again because now the intermuscular septum can still be a point of constriction, but now it's just on the other side of the nerve. Then it's the medial head of the triceps, especially with guys that have and women that have very well-developed medial head of the triceps. That can be pushing the nerve into the intermuscular septum. Osborne's ligament is a ligament that's over the ulnar nerve at the level of the medial epicondyle. The medial epicondyle itself can be a point of constriction. The enchyneus epitrocularis is an anomalous muscle. It's basically an enchyneus on the opposite side on the medial side of the elbow. This sits right at the medial epicondyle, and that can be a point of that probably will compress an ulnar nerve. I think that many times those patients are always symptomatic, but that's just my theory. And then it dives in between the two heads of the FCU, and that can be a point of constriction. So just know that as you go down. Atypical sites, we talked about the enchyneus epitroclearis. It's an uncommon muscle. It's an anomalous muscle. Malunion, cubitus veris, can be a cause, or cubitus valgus. So basically, any elbow deformity. I listed cubitus veris, but it's actually more likely going to be cubitus valgus, putting an extra stress on that nerve as the elbow is taking a valgus deformity. Osteophytes. So if someone has pretty significantly advanced osteoarthritis and osteophytes in that, around that medial epicondyle. And then heterotopic ossification. Cysts, masses, also just think of that. Heterotopic ossification. If someone has really significant heterotopic ossification of the elbow after an elbow fracture dislocation, you have to, if you're going to release the elbow, you have to explore the medial side and release the ulnar nerve, because that ulnar nerve could be encased in bone. And if you manipulate the elbow, you could cause a severe injury to the ulnar nerve by basically rupturing the ulnar nerve, because it's encased in bone and you break the ulnar nerve. So if that comes up as a question with HO, explore the ulnar nerve, find the ulnar nerve, decompress the ulnar nerve, and release it from bone. In regards to the cysts and the masses, if someone has a pretty atypical mass around the elbow that could be compressing the ulnar nerve, and they show you an MRI, think possible synovial cell sarcoma. I know this is not a tumor talk, but just having a mass around the elbow is pretty weird. Having a ganglion cyst there is pretty weird. So if you see it, you have to think, okay, this might be malignancy. Clinical presentation, ulnar, 1.5 digits, so opposite of the median nerve. So the radial border of the ring finger is median, ulnar border of the ring finger is ulnar, and this is true. Patients really do present like this. Shooting pain down from the elbow. And nighttime symptoms, difficulty with fine motor movements, buttoning buttons. So make sure you differentiate this from cervical myelopathy or radiculopathy. Also talking on the phone. So a positive elbow flexion test. So what that is, they bend their elbow, they hold it bent for 30 seconds to an hour. So same concept as a phalanx for a median nerve, except here, instead of flexing the wrist, they're flexing the elbow. Thenars at the elbow, decreased sensation on the dorsal ulnar aspect of the hand. So if you look at the diagram, this is important to differentiate cubital tunnel syndrome from a more distal ulnar nerve pathology. That in cubital tunnel syndrome, the dorsum of the hand should be affected as well. If it's not affected at all, and only the palmar surface of the hand is affected, then you have to think, I don't think the ulnar nerve is injured up by the elbow. It's probably more distal, down by the wrist. Specific exam findings. You will have a tremendous amount of specific exam findings for ulnar nerve pathology. I don't think they'll ask you about this, but Frommans, Wartenberg, Gian, Moss, Pollock. Honestly, I don't know what a Gian, Moss, and Pollock examination are for ulnar nerve. It's not important. Froment is when you pinch paper. Are you compensating, and are you now using the FPL because the adductor isn't working? That's a more common one. Wartenberg is that the small finger is deviating dorsally and ulnarly, and that's because of overpull of the extensor digitorum minimus, because you don't have the adductor of the small finger pulling it back in. Nerve connection study EMG, just like carpal tunnel, is helpful. It's less helpful than in carpal tunnel syndrome, though. Ultrasound has not been validated as it has to the same degree in carpal tunnel syndrome, so I don't think you'll be asked that. But just remember, in carpal tunnel syndrome, you could have a question, and ultrasound is a legitimate modality and for diagnosing carpal tunnel syndrome. Okay, so when patients present with severe presentation, they have wasting of the intrinsic muscles of the hand, and they have clawing of the ulnar two digits, and they have difficulty with fine motor. Now, the clawing of the ulnar of the two digits is important for you guys to pay attention to. Okay, why do you have clawing of the ulnar two digits? You have clawing of the ulnar two digits because your intrinsics are not working. Which intrinsics are not working? Your lumbricals. Your lumbricals for your ring finger and your small finger are not working. And remember, your lumbricals flex at the MP and extend at the IP joints. So when your lumbricals aren't working, you have overpull of your extrinsics, your extrinsic flexors and your extrinsic extensors, and so you hyperextend at the MP joint and you're flexing at the IP joints. Flexion of the IP joints is the extrinsic flexors, so the FDPs. And then your extrinsic extensors are hyperextending at the MP joint. So that's why clawing. However, if you are astute, you'll think, wait, if you have cubital tunnel syndrome, your extrinsic flexors, your FDPs, should be affected as well. And you are correct. So you will see some clawing with really severe cubital tunnel, but it won't be severe clawing. Severe clawing comes in when you have a more distal injury, when you have a completely normal FDPs and FDSs, but your intrinsics are affected. So we'll get to that. So you'll have minor clawing. So a little detail to focus on. Treatment, rest, elbow braces. Elbow braces actually do work for this, but who can tolerate wearing an elbow brace like this for pretty much all day long for 4 to 6 weeks? But it is something that needs to be trialed. Surgery, in situ release, transposition, medial epicondylectomy. There is not great evidence that supports one for the other. So they will not ask you, I do not think, should this patient require in situ release or a transposition for a primary cubital tunnel patient. However, if you have revision, then there is evidence to support for a submuscular transposition for revision. So that is something that could come up and they could ask for revision ones, not for primary. When you do surgery, the most likely thing to injure, other than the median nerve itself, is the medial antebrachial cutaneous branch. This can give you painful neuromas. So pain over the medial side of the elbow after the surgery, you have to think medial antebrachial cutaneous injury. Recurrence can occur if you do an in situ release and there's subluxation of the ulnar nerve, scarring of the ulnar nerve, or if you transpose the nerve and now there's a new area of kinking of the nerve. Either you didn't release the intermuscular septum, and so there's kinking proximally, or you didn't release the FCU distally, so there's kinking of the ulnar nerve as it makes that course from an anteriorly transposed position. Now it's diving back to its normal posterior position. So subluxation after in situ release can cause recurrence, and kinking either proximate at the intermuscular septum or distally at the FCU. Okay, so I'm just jumping to nerve injury. The reason I'm jumping to nerve injury is because I think this could be the second most commonly area that you'll get tested on. There's a lot that we could write about nerve injury, a lot that we could say. I think the overwhelming majority of it is way too much detail for you, but this one slide is busy, but this is, I think, all that you need to take away from nerve injuries. Oh, that, and also learn the brachial plexus. Just spend 30 minutes one day and memorize the brachial plexus and draw it out on the day of. But in regards to nerve injury, the reason why I want you to pay attention to this slide and just spend time with this and look at it and learn it is when you have a patient that has a nerve injury, you have to think, what type of nerve injury do they have? If people say, oh, they have a neuropraxia is a very specific type of nerve injury. What that is that the nerve is intact. You look at the nerve under the microscope, you look at the nerve grossly, it's intact. That's going to recover on its own. You don't need to do anything, just time. So, a humeral shaft fracture, and they say, the general teaching is if it's a closed injury, don't explore the radial nerve unless you're planning on doing surgery anyways. The reason why is because they assume that the injury is a neuropraxia, and there's good reason to believe that it's a neuropraxia with a closed humeral shaft fracture. If you knew that it wasn't a neuropraxia, then leaving it alone and watching it is very possibly not the right thing to do. So if you get presented with a question in the test, you have to think, all right, are they telling me a story where they're trying to make me think that the nerve is intact, or the nerve got cut, the nerve got ruptured, the nerve got lacerated? An axonotmetic injury is where the axons are disrupted, so the internal structure of the nerve is disrupted, but the external contents, the external structures of the nerve are in continuity. This is bad, but better than the other ones. So axonotmetic injuries, they may or may not recover. So that's one of the things to if it's not going to recover, then surgery. But this is something you're more likely to leave alone. Now the next layers up is where the nerve has been completely transected, a neurometic injury. Neurometic injury is where there's nothing in continuity. A neuroma in continuity is that the nerve was so severely injured, but there's stuff that formed in the middle, but it's completely disorganized junk that is essentially the same as a neurometic injury. Those are the injuries that need surgery. What surgery do they need? Nerve repair, nerve transfers, nerve grafting, tendon transfers, things like that. But the exact type of surgery, I don't think you need to worry about. But just try to decipher what type of injury did this patient get. A neuropathic injury, leave alone. Axonotmetic injury, I doubt that they'd give you a scenario like that, but they'll probably give you a neuropathic injury, leave alone, or the nerve got ruptured, the nerve got transected. There you're operating. There's no reason to wait. All right. Next is ulnar nerve tunnel or Guillain tunnel pathology. Know the anatomy. It sits on the transverse carpal ligament. So when you cut the transverse carpal ligament, you're relaxing Guillin's canal because you're relaxing the floor. The volar carpal ligament sits over this. The pisiform is on the one side. The hook of the hamate is on the other side. So just remember, it wraps around the hook of the hamate. Common causes here, unlike cubital tunnel syndrome, masses are a common cause of pathology, specifically ganglion cysts or lipoma. Repetitive trauma, ulnar hammer syndrome, ulnar artery aneurysm, ulnar artery thrombosis, hook of the hamate fracture, non-union. Those are all common causes. So you have to think, could it be one of those things? Idiopathic occurs too, but ulnar tunnel syndrome, more common than cubital tunnel, has a specific cause that you can identify. Where the injury or the site of compression is affects the symptoms. The more proximal it is, it's going to be motor and sensory. The more distal it's going to be, it's either going to be just motor or just sensory. Just remember, the motor branch dives deep. The superficial branch is the sensory branch. So if it's distal, if it's a superficial injury, it's most likely it's just sensory. If it's deep, then it's going to be your motor. Evaluation here, radiographs are very helpful, especially the carpal tunnel view. That's for hook of the hamate fractures or hook of the hamate non-unions. MRI for mass, for non-union. Can be helpful. Ultrasound as well. Nerve conduction studies, EMGs if the symptoms are severe. CTA, MRA, Doppler ultrasound for ulnar artery thrombosis or ulnar artery aneurysm. And a physical exam, compression of the ulnar nerve at the wrist, like a Durkin's, can be helpful as well. Differentiating Guillin's versus cubital tunnel. Coming back to the clawing. In Guillin's, they will have more severe clawing. Remember, they have more severe clawing because the intrinsics are affected. So the FTP, the lumbricals are not working, but they have normal FTP. So you have really strong finger flexion, but you have nothing to counteract the IP flexion. And Thenars at the wrist as opposed to Thenars at the elbow. Conservative measures, of course, always rest, splinting, NSAIDs. and then surgery, decompressing it, mass excision, ulnar artery reconstruction, or ulnar artery thrombosis excision if they have an intact arch. So remember that if they have a normal Allen's test, you can just excise the ulnar artery. Radial tunnel and PIN syndrome. I lumped these two together. They are many times confused, but they are not the same diagnosis. But realistically, they probably are just variations of the same pathophysiology, is my opinion. But radial tunnel is pain. It does not have sensory or motor pathology. It makes it very difficult to diagnose. And that's what makes it so you can't pick it up on EMG, nerve conduction studies. You can't pick it up on MRI. You can't pick it up on ultrasound. It is only pain. And it's confused with lateral epicondylitis, but the way that you differentiate this from lateral epicondylitis is that you have pain not over the lateral epicondyle, but just distal to it, over the dorsal proximal forearm with pressure. It will reproduce our symptoms. Or if you have resisted middle finger extension, reproduces pain over the proximal dorsal forearm. That makes you concerned for radial tunnel. So lateral epicondylitis and radial tunnel, we think, coexist around 5% of the time. It is a challenging diagnosis to make. We talked about the diagnosis of pressure. Resisted forearm supination or passive pronation with wrist flexion. Why can that cause symptoms? We'll get to that, but it's because of the possible structure, the possible sites of where the radial nerve can be compressed, and so those motions are aggravating the nerve by causing greater pressure. So posterior interosseous nerve syndrome is motor. It's predominantly motor. It is a motor diagnosis. So these are the patients that come in with a wrist drop. So wrist drop won't give PIN syndrome. You don't see wrist drop in PIN syndrome. Why don't you see wrist drop in PIN syndrome? Because the ECRL is innervated by the radial nerve already. But these are the patients that have radial deviation with wrist extension. So their wrist extension is weird. And they can't. They're using their intrinsics to extend their digits, and they have no APL, EPB, EPL function. So PIN syndrome is a motor. It's the same region as the radial tunnel syndrome, but the presentation is different. Now, what are the possible sites of pressure or compression on the radial nerve? So you have fibrous bands sitting over the radiocapitellar joint. Remember that the nerve is sitting right on that radiocapitellar joint. You have the leash of Henry, which are a bunch of vessels, the radial recurrent vessels off the radial artery. You have the arcade of Froese. This is the tendinous portion where the nerve is starting to dive into the supinator. The supinator has two heads, so it dives between the two heads of the supinator, and the arcade of it's actually Froese, is that leading edge of the supinator, and then you have the distal edge of the supinator. Conservative treatment is always, that's like the recurrent thing that we always do with all of these. Steroid lidocaine injection is helpful for radial tunnel because remember, it's a pain. So if you inject lidocaine, if you inject a steroid, and they have immediate relief of symptoms with lidocaine, that's great. And then with steroid, they may have relief that lasts for a couple of days, a couple of weeks, or even a few months. Surgery doesn't bear great results with radial tunnel, and I think that's because it's a difficult diagnosis to make. So they don't do well because you didn't diagnose them well. Is my theory. PIN syndrome, different story. If they have a PIN syndrome and you find the point of compression, they do well. Oh, one of the things to note is many times masses. So a cyst can sit there and cause pressure. So one of the things to think about, if someone comes in, if they present you a scenario and they say, hey, this patient is unable to extend their digits, They have no EPL function, this or that. One of the things that you have to quickly decipher is this a tendon rupture? Is this an attritional tendon rupture seen with an inflammatory arthropathy, with a patient with rheumatoid arthritis? Their tenodesis will be abnormal. So when you take the wrist passively flexing and extending, the finger motion there will not be normal. They won't have that passive extension of the digits with wrist flexion and the passive finger flexion with wrist extension. But if they do, then you have to think, it's a nerve problem, and you have to think, could it be PIN syndrome, and then could it be a cyst or synovitis sitting over the nerve? And so you can, with inflammatory arthropathy, it's not an attritional tendon rupture, it's actually it's a inflammatory synovitis sitting over the PIN, compressing the PIN. Okay, next is pronator syndrome. Pronator syndrome is of the median nerve compressed in the form, idiopathic most of the time, muscular forms, tennis players, people that use their forms a lot, especially with pronation, develop a lot of muscle mass around the median nerve that can compress the median nerve. Sites of compression, just like you do with radial tunnel and PIN syndrome. First one, supracondylar process. Very uncommon, but get an x-ray. Get an x-ray, you see the supracondylar process, and you have to think, okay, this could be a site of compression. Next, related to that, is the ligament of Strutters. The ligament of Strutters is that ligament that goes from the supracondylar process down to the medial epicondyle. That's for median nerve. Arcade of Strutters is ulnar nerve, and that's a different structure through the intermuscular septum. The nerve is coming through the intermuscular septum. Just remember, ligament is M, median nerve. The ligament of Strutters and the arcade of Strutters are right by each other, so that's probably why they both use the term Strutters. Bicipital aponeurosis, Lacertus fibrosis, is actually a pretty common point of compression too. So if someone has a very well-developed biceps and the Lacertus is tight, especially if someone has a biceps tendon rupture and you repair it down and you tighten it, you pull it down farther, now that Lacertus is even tighter and it can be a point of compression. The median nerve dives between the two heads of the pronator, just like supinator the supinator for the radial nerve or for the PIN. This is a problem for the median nerve as well. And just distal to this, it goes between the origin of the FDS muscles. That aponeurosis can be a point of constriction as well. Okay, how do you differentiate pronator syndrome from carpal tunnel syndrome? Pronator syndrome, they have less nighttime symptoms. Their pain is over the forearm. Certain physical activities reproduce it. But a very specific thing is abnormal sensation over the thenar eminence, because that is from the palmar cutaneous branch of the median nerve. That nerve is not affected in carpal tunnel syndrome. Why? Because it takes off proximal to the transverse carpal ligament, and so it's not in the carpal tunnel. It's superficial to the carpal tunnel. So, but if they have abnormal sensation over the thumb, over the base of the thumb, not at the pulp of the thumb, but over the base of the thumb, thenar eminence, that is a more proximal median nerve injury. Okay, different provocative tests as well. So you have to think all the sites of potential compression of the median nerve. What can you do to tighten that area to reproduce the symptoms? Okay, resisted elbow flexion with supination. Why? Lacertus fibrosis. It tightens the Lacertus fibrosis. Resisted pronation with elbow extension. What does that do? Well, it's the opposite, but that's if you have, if it's at the two heads of the pronator. So you're flexing the pronator, forcing the pronator to work harder, and you're extending the elbow, so you're putting more tension on the pronator. Because the pronator, of course, originates from the medial epicondyle. Resisted finger flexion with wrist extension. FDS origin. The FDS work more. You put them on tension. So these provocative tests are all very different, but that's because it's different sites of compression potentially. Treatment, same as all the others, conservative management, ultrasound, EMG, nerve connections, MRI, not very helpful for this, by the way. And then if conservative measures don't work, then surgery. Surgery can be very helpful for this. AIN syndrome. AIN syndrome is the last thing that we'll cover. This is oftentimes idiopathic, oftentimes associated with a brachial neuritis. Which of these two has AIN syndrome? Well, it's the hand on the right has it. How do we know this? AIN innervates pronator quadratus, innervates the flexor pollicis longus, and innervates the flexor digitorum profundus of the index and plus or minus the middle finger. So they're not able to flex the DIP of the index. They're not able to flex the IP of the thumb. So they're not able to make an AOK sign. And you'll see the middle finger and the ring finger on the hand on the right also extended. So treatment for this is highly debated, but typically if you get presented with this question, you observe, and then maybe surgery. One of the reasons why you're not aggressive with surgery with these, at least for board purposes, is because tendon transfers help patients recover pretty well for FPL function. And so that does work well for these patients. I think that's it for this. Let me know if you have any questions. Hopefully this is helpful. Hopefully we just covered the pertinent stuff. All the best, and let me know if I can help you guys at any time in the future. All right, bye.